I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about how I think about fertility testing, what to order, what to skip, my framework when I see a new patient. So when I first see an individual or a couple, I always take a thorough history, right? That's where I start. And again, I was taught in medical school that most of the things I need to know, I could learn from the patient themselves. And I really do stand by that in fertility medicine because there's so much we can truly glean by taking careful history. So I want to know menstrual history. I want to know menstrual patterns. I want to know if the menses are heavy, if they're painful, if there's intermenstrual spotting. I want to understand if there's, significantly pain outside of the time of periods. I want to understand all these things. I need to know if somebody's been pregnant before, or maybe in a different relationship. Maybe they were successful with a different partner, and now they're in a second marriage, and things aren't connecting as easily, right? There's the full gamut of all the testing that we get. That's really, really important. I want to know if anybody has any sexually transmitted infections. I want to understand if, people have had significant abdominal surgery. I want to understand if people gain some weight and all of a sudden their cycle's spaced out, right? So there's so many different questions that we ask that try to get at the question of like, what is the state of this person's reproductive system in general that are really important. That having been said, I will say pretty routinely, I always check an anti-Mullerian hormone. What is an AMH? That is that serum test that can be drawn at any point in the cycle that helps us understand basically how many eggs somebody has relative to their age. And so it is a very useful test for us. And you can't say you're infertile or not based on the AMH, but you can say, at least quantitatively speaking, you have an expected number of eggs for your age. I will usually check a follicle stimulating hormone and an estrogen. Now, if somebody has transportation issues or they really want answers now and they're going away for their day 3 labs, sometimes I'll forego that. But I will tell you, I learned so much from the follicle stimulating hormone and the estrogen. I learn, how hard the brain is working to keep the cycles going. I understand if maybe the day 3 estrogen is elevated, maybe somebody has recruited a follicle on the sooner side, and I really am worried about diminished ovarian reserve. I will often also check a baseline LH because especially in female physicians, I see a lot of sort of lean PCOS or hypothalamic amenorrhea. So that also helps me understand somebody's diagnosis. So day 3 labs are really important from my perspective because they help me understand the physiological picture about the communication between the brain and the ovaries. I will also generally get an antral follicle count because that helps me understand how many eggs somebody goes through in a given month. So say, somebody goes through 10 eggs in a given month but ovulates 1, or somebody goes through 25 eggs in a given month and ovulates only 1. The person with the 25 group size will probably have more eggs to work with in an IVF setting. It also helps you with response to medication. So, not only is an internal ultrasound helpful to understand the pelvis and the myometrium, and if there's any, polyps or fibroids, I usually throw a little fluid in there just for a sonohistogram. But I think that it's also really useful for me to understand the antral follicle count as I help to counsel people, especially in terms of their response to meds. It can also be really helpful if there's discordance, right? Say the AMH is really high, but the antral follicle count is really low, or vice versa. Sometimes it can help me understand if somebody might have like a DOR/PCOS phenotype. Sometimes those two tend to cancel each other out. Sometimes if the AMH is unexpectedly low, it can tip me off to endometriosis. Not always, but sometimes. And so I would say, for most people in the fertility realm, I get AMH, day 3 FSH, estradiol, LH, and then an internal ultrasound for antral follicle count. Bonus points if we can get the sonohistogram and the hycosi, that fluid through the tubes, to make sure that the tubes are patent. If somebody has true risk factors for fallopian tube disease, such as like significant abdominal surgery or STI history, or let's see, maybe they have a previous ectopic pregnancy, any of those things, I will generally get a hysterosalpingogram as well to make sure we're truly understanding the patency of the fallopian tubes. Endometriosis is another one. If somebody has a history of endometriosis, I really want to understand the nature of the tubes. And, along with that, if they've had previous abdominal surgery, that's really helpful as well. Okay. So I think about eggs. We talked about, ovarian reserve testing. I think about uterine cavity and fallopian tube structure. I think about preconception testing as well. So that's sort of the third category. And that is to make sure that you are optimized to be a pregnant person. So within that, I think about the complete blood count, making sure that somebody is optimized from an, anemia standpoint, that they're not anemic going into a pregnancy. Also, especially if I'm going to do IVF and I'm going to put a needle in the pelvis, I really want to know what their baseline CBC is. So it kind of is twofold in that way. I get a type in screen, make sure that there's no, antibodies that we need to worry about. I get a rubella, chickenpox, measles antibodies to really understand somebody's immunity. We give a booster if somebody's not immune. And then we will, I'll usually offer people STI labs. If somebody's doing IVF, we're going to need them anyway in terms of like HIV, Hep B, Hep C, syphilis. But at least at our clinic, we have a policy that if somebody's going to do an IUI, they need a gonorrhea chlamydia on file. And so again, I always say, not because I think you have it, but because we test everybody for it. I usually try to get a urine as well. Let's see, vitamin D. I check vitamin D pretty much in everybody, as long as our insurance will cover it, because the studies have shown better outcomes when vitamin D is repleted. And if somebody also has like PCO type phenotype, I will get a testosterone level and a 17-hydroxyprogesterone. I typically don't get a DHEAS, even though that was part of my training when I studied for my boards. I look through the data, and if somebody's testosterone is elevated, then I'll get it. But usually I try to save money for the healthcare system and don't get that off the bat. If somebody's an ovulatory or oligo-ovulatory, I will typically get a prolactin and a TSH. I have a whole other episode about TSH. It's kind of controversial, but I am trying to roll back my TSH testing based on the guidelines. I do still feel like there's a number of people who do meet criteria for thyroid screening, and so I will often get that from my people. But that is sort of part of my initial testing if somebody is symptomatic or if they have a strong family history or recurrent pregnancy loss, et cetera. Okay. Expanded carrier screening. Now, it's interesting because it's not a fertility test per se, but when I was in training, I was taught to order cystic fibrosis and spinal muscular atrophy on everybody, or at least to offer it. And now we actually have these panels where you can get tested for hundreds of mutations at a time. And if you have a partner, they can get screened too, to make sure that you're not sort of sharing any similar mutations that might give you a child with a recessive gene mutation. I even have same-sex couples who actually like to both check their status so that they can get a sperm donor, especially if they're going to use the same sperm donor, who is going to be compatible with both of them and not just one or the other. And so I think it can serve a lot of purposes. Sometimes it's out of pocket, but it's usually just a few $100s to get it done. I'm not minimizing that, but again, thinking about having a kid with a lifelong disease that can be screened with IVF versus, understanding this ahead of time, preconception, and going that route, for me, it's worth the money personally. And so, these are sort of the preconception labs, like I said, like optimizing your CBC, your TSH, your vitamin D, getting those ancillary tests if I'm worried about inoculation. Also an A1C, I will usually get an A1C if I'm worried about obesity or strong family history of diabetes or current pregnancy loss as well. Or PCOS, I get it. Even people with lean PCOS can have an elevated hemoglobin A1C, so I check that as well. And so those are the tests that I really try to get on my new patient appointment, at least from the female perspective. Now, the fourth category is the sperm. So the sperm, often overlooked. Many people say in the beginning they just want to focus on themselves. For some reason, it is crazy hard to get men to come in and produce sperm into a cup. I know it's awkward. Thankfully, after COVID, we now have people produce at home and bring it in, especially if they're within an hour of the clinic. But it really is 40% of heterosexual infertility. And if we're not paying attention to that, we might subject a female to like months and months of testing and finally get an answer that we've wasted time and somebody's older now and they're still at where they were before. And so getting a semen analysis is really important. We look at numbers, shape, movement. If the analysis is abnormal, we would generally repeat it a second time. We have a reproductive urologist we can work with to, do further lab testing for the male side of things if that is needed. So, what I would say is there's egg reserve testing, there's uterine cavity testing and fallopian tube testing, there's preconception testing, and there's semen analysis testing. There's a whole slew of things I don't recommend screening for instance, like all the Reproductive immunology labs, generally speaking, those are very expensive, and they have not, the data has not borne out for those. Any sort of expanded, hypercoagulability panel, that has not borne out. Even recurrent pregnancy loss, even still the only thing that's evidence-based from a coagulation, perspective is the antiphospholipid antibodies. And so I think, people do spend a lot of money on testing. I'm all for leaving no stone unturned, but I think we have to know like what's evidence-based, what's not evidence-based, when to get the PCOS labs, when to, double check the sperm test, when to, do a recurrent pregnancy loss evaluation. That can be really important, but especially at a new patient infertility visit, these are the staples. These are the things I'm really looking for, that when I see somebody again at their next visit, I'm going to have all the data that I need to make, to help people out. Now, I will say there are some nuances, like people will say, what's the best cavity evaluation for me? Anything where you can see and see if there's any pathology or not. So for most people, a sonohistogram is going to be, beautiful because it allows for a comprehensive evaluation of the pelvis. You can get the antral follicle count at the same time. You can typically put some bubbles through the fallopian tubes and confirm tubal patency. So it's a very comprehensive test. But we can get fooled, right? Especially if the patient's on the heavier side and it's harder to see those bubbles, especially if somebody really does have risk factors for tubal disease, and you can see the bubbles go into the fallopian tubes, but you don't necessarily see them come out of the fallopian tube. And so, my general rule of thumb is if I'm really worried about somebody's fallopian tubes, I'm going to get an HSG, right? If I'm really worried about somebody's cavity in their pelvis and I'm going to get a sonohistogram, I don't think it's wrong to get both tests. I know it's kind of annoying to go as a patient, but they give me different information. And so, even recently, I did a sonohistogram on somebody who had a normal HSG just a couple months ago, and she had a big, huge polyp in there because sometimes HSGs miss polyps and filling defects in the cavity. So again, sonohistogram better for the cavity, HSG better for the tubes. Again, why not get both if I'm worried about both? Again, for most people, a sonohistogram with a hycosis is going to be very acceptable, but these are the questions to ask your REI to say, like, why am I getting this, test and not this test? When would a hysteroscopy be warranted? Especially if somebody is, not getting pregnant after several IVF cycles. I really want to look at the tissue health, which, sonohistogram and hysteroscopy, basically very similar test characteristics as to understanding if there's filling defects present. But if I can look directly with a camera and see the tissue and understand, does it look healthy? Does it look gray? Does it look yellow? Does it have micro polyps? Am I concerned for chronic endometritis? All those different things. I'm going to be able to see a little bit better, actually a lot better, with the office hysteroscopy compared to the sonohistogram. So again, these are the things I think about as I'm thinking about how to take very good care of patients. It is not a one size fits all, as I think you can see. Every single person deserved a personalized, tailored approach to their particular situation and their story. But again, these are evidence based. There are many things, many panels that you can read about that are not evidence based. I think that there, unfortunately, are people who will run those tests and spend a lot of money, a lot of the micronutrient stuff, especially as well. So just be aware. If you ever have a question, send me a DM. I'm happy to help you sort out what tests are right, or even, do a more in-depth consult to help point you in the right direction. Okay, my loves, you know how much I love you. Until the next time. Bye.